I need to tell you something that has been weighing on me for a very long time. And I know the moment I say it out loud, some of my colleagues are going to be deeply uncomfortable. But after more than 3 decades in medicine, after sitting with families in hospital corridors, after watching what happens to seniors who said yes without asking the right questions, I cannot stay quiet anymore. I am talking about surgery. Not all surgery, but 3 specific operations that are routinely recommended to people over 65. Procedures that look responsible on paper, but carry risks most surgeons never fully explain. I can already hear you thinking, but my doctor said I need this. Stay with me. My name is Dr. Derek Greenhaw. I spent 31 years as a board-certified general surgeon. I have performed hundreds of operations. I have also stood at bedsides afterward watching seniors struggle with complications nobody warned them about. Infections that wouldn't heal. Muscles that never recovered. Minds that never came back the same after anesthesia. After age 65, your body processes surgery differently. Your immune response slows. Your recovery window narrows. And the margin for error shrinks significantly. I am not here to frighten you. I am here because the informed patient always does better. Always. Before we go any further, I want to ask you something. Do you have a parent over 65? A spouse? A sibling? Maybe it is you who has been handed a surgical recommendation and told to schedule it soon. If that is you, or someone you love, type the word surgery in the comments right now. I read them. And what you share helps me understand exactly who I am talking to. Also, if nobody has told you to subscribe yet, please do. Every week I share what most doctors simply do not have time to tell their patients. Now, let us get into it. First, your liver and kidneys process anesthesia more slowly. That means the drugs stay in your system longer. For some seniors, that lingering chemical load is enough to trigger something called postoperative cognitive dysfunction. Memory fog. Confusion. Personality changes. Sometimes temporary. Sometimes not. Here is what most surgical consent forms will never tell you. After 65, your body is not the same patient it was at 45. And that changes everything about how surgery lands on it. Second, your muscle tissue loses its ability to repair quickly. Surgeons call this sarcopenia. What it means for you is that the cutting, the retraction, the trauma of even a routine operation can leave muscles weakened in ways that take months to recover, if they recover at all. Third, your immune system, which should be your greatest ally after any procedure, is operating at a reduced capacity. That makes wound infections, pneumonia, and blood clots far more likely in seniors than in younger patients. None of this means surgery is always wrong after 65. It means the threshold for saying yes must be much higher. The risk calculation has genuinely changed. And most surgeons are not stopping to recalculate it with you. Surgery number 1, spinal fusion. Sarah was 68 years old. A retired schoolteacher from Ohio. She had chronic lower back pain, real pain, the kind that made mornings brutal. Her orthopedic surgeon told her spinal fusion would stabilize her spine and give her her life back. She believed him. What Sarah did not know was this. Spinal fusion does not just fuse the problem vertebrae. It transfers mechanical stress to the joints directly above and below the surgical site. In seniors, those neighboring joints are already compromised. Within 18 months, Sarah had developed what surgeons call adjacent segment disease, new pain, in new places, worse than before. The research backs this up. Studies show that seniors over 65 who undergo spinal fusion face a significantly higher rate of reoperation within 2 years compared to younger patients. And each subsequent surgery carries compounding risk. What Sarah needed was an aggressive, structured physical therapy program, something she was never offered. Her daughter told me, "We wish someone had said wait." But wait, if spinal fusion carries these risks, what about the second surgery on my list? This one is performed hundreds of thousands of times every year. And almost nobody questions it. Now I want you to stay with me here. Because what I just told you about spinal fusion, the adjacent damage, the reoperations, the compounding risk, that is troubling enough on its own. But the second surgery on my list is different. And in some ways, far more alarming. Because spinal fusion is at least a procedure most people pause to think about. Most people ask questions. Most people get a second opinion before agreeing to have their vertebrae permanently bolted together. The surgery I am about to describe? People say yes to it the same afternoon they are diagnosed. They are handed a referral, given a surgery date, and told this is simply what you do next. No waiting. No exploring alternatives. Just schedule it. And here is what breaks my heart about that. For a significant number of seniors over 65, this particular surgery does not extend life. It does not meaningfully improve quality of life. But it does carry a recovery burden that can trigger a cascade of complications most families never anticipated. Are you still with me? Good. Because surgery number 2 is one that somebody you love may already be facing right now. Because here is what I know after 31 years in medicine. The seniors who do best are not the ones who simply said no to surgery. They are the ones who said, not yet. Show me what else is possible first. And there is always something else possible. The human body, even at 70, even at 75, has a remarkable capacity to respond to the right interventions. Conservative interventions. Targeted interventions. Approaches that do not require a scalpel, a ventilator, or a 6-week recovery that quietly steals independence. So in this second part, I want to give you something genuinely useful to walk away with. For each surgery I named, I am going to tell you what the evidence actually supports as a first-line approach. What questions to bring to your doctor. And what a second opinion should specifically include. This is where it gets hopeful. Stay with me. The better alternative to spinal fusion, structured conservative care. Let me tell you about Philip. 71 years old. Same diagnosis as Sarah, degenerative lumbar spine disease. Same level of pain. His surgeon recommended fusion immediately. Philip asked for 90 days first. In those 90 days, he worked with a physical therapist who specialized in spinal rehabilitation for older adults. He was prescribed a targeted anti-inflammatory protocol. He made 3 specific modifications to how he slept, sat, and moved through his morning routine. At the 90-day mark, Philip's pain had reduced by more than half. He never had the surgery. 3 years later, he is still walking his dog every morning. The research supports what Philip experienced. A landmark study published in the Spine Journal found that for the majority of seniors with degenerative spinal conditions, structured conservative care, physical therapy, guided movement, and pain management produced outcomes comparable to surgical intervention. Without the surgical risk. So before any senior agrees to spinal fusion, I want you to ask your surgeon 3 specific questions. Has a structured physical therapy program been attempted and documented? What is the reoperation rate for this procedure in patients my age? What does my quality of life look like if I wait 6 months and try conservative care first? If your surgeon cannot answer those questions patiently and completely, that itself is your answer. You have not run out of options. You have simply not been shown all of them yet. I want to give you something concrete before we close. Because information without action is just worry. And you deserve better than that. Here is your senior surgery protection plan. 5 steps you can take starting today. Step 1. Never accept a surgical recommendation on the same day you receive it. Ask for time. A responsible surgeon will respect that request. A surgeon who pressures you to decide immediately is a surgeon worth getting a second opinion from. Urgency is legitimate in genuine emergencies. Elective procedures do not qualify. Step 2. Request the specific complication data for your age group. Not general complication rates. Your age group. Ask your surgeon, what is the complication rate for patients between 65 and 75 who have undergone this specific procedure? If they do not have that number readily available, that tells you something important. Step 3. Insist on a conservative care trial first. For the vast majority of conditions leading to elective surgery in seniors, a documented trial of conservative care, physical therapy, targeted medication, lifestyle modification, is both reasonable and evidence-supported. Ask for it explicitly. Get it documented in your chart. Step 4. Always get a second surgical opinion. From a surgeon who does not perform that procedure. This is critical. A spine surgeon profits from spinal surgery. Seek an opinion from a physical medicine and rehabilitation specialist, a physiatrist. Their incentive is your function, not your surgical calendar. Step 5. Bring someone with you to every surgical consultation. Every single one. A second set of ears in that room catches what fear and overwhelm cause you to miss. That person's one job is to write down every answer and every question that does not get asked. You are your own best advocate. And now, you know exactly what to say. If this video gave you something your doctor's appointment never did, please share it. Send it to someone who is facing a surgical decision right now. A parent. A spouse. A friend who just got a referral and hasn't asked a single question yet. That share could be the most important thing you do for them today.